Welcome to Understanding the Power of Palliative Care. We have Amy Robinson and Ashton Goldsmith-Webb here today from Agape Care Group today. So they're going to talk a lot about the power of palliative care, as by the title. So both of them come to us with a tremendous amount of experience in palliative care and the power that families can get from it. So as someone who experienced that myself back at home for my son, it was life-changing in so many different ways. And I think there's a lot of mystery around what palliative care is, so I'm hoping that they can help explain some of that, and then there will be plenty of time for questions. So without further ado, Amy, Ashton.
Hey guys, can everybody hear me okay? Great. I'm going to go ahead and tell y'all, just going to preface this, I am a boots-on-the-ground provider. I do not normally do these kinds of things. I am with my patients 5 days a week, Monday through Friday. So if there are any hiccups, if I seem nervous, I am so sorry. And there will be time at the end for questions, and I will answer them to the best of my ability, and so will Amy. So just kind of want to let you know there's not going to be any big bells and whistles or anything fun. It'll just be kind of straight and to the point. How many of y'all, just a show of hands, are familiar with palliative care or have had a family member, loved one on palliative care? Okay, great. That's awesome. A lot of times we get the question, what is palliative care? There's a lot of confusion around it, and honestly, sometimes it's hard to explain because I feel like I wear so many hats, and it really depends on the patient that I'm seeing what I'm doing for them, what kind of care I'm providing. So, for patient A, I may be doing more of social and spiritual care. Patient B, I may be doing more symptom management. So it really depends on a patient-by-patient basis, kind of what their needs are. All right, so what is palliative care? It is a specialty. It's just like going to see your cardiologist, your pulmonologist, but we focus on the patient as a whole in their illness. So we're going to focus on bringing patients and families relief from symptoms, pain, and the stress of that serious illness. Our goal is to improve your and your family's quality of life. We're going to talk a lot about goals of care, sitting down. What are your goals? Are those goals realistic? And develop an individualized plan of care, not just based on your illness, but also on what's important to you. What does quality of life mean to you? It is appropriate at any age and at any stage of the illness. And it is congruent with disease treatment. So you can be pursuing aggressive curative treatment and still be under palliative care. So there's no rules or anything like that where you can't be pursuing aggressive treatment. So palliative care came out of hospice. It became a specialty in 2006, and it focuses mainly on 3 domains. Pain and symptom management. Some of them are just, nausea, delirium, constipation, shortness of breath, anorexia, but it can be any of them. The psychosocial and spiritual support, and then again, advanced care planning. So kind of comparing and contrasting palliative care and hospice, because we get a lot of questions about what is the difference. So palliative care, one of the biggest differences is it can be in any stage of your disease process. You can be seeking curative treatment, whereas hospice, it excludes that curative treatment. We're typically looking at a prognosis of 6 months or less. They both have that multidisciplinary team approach, so both focusing on quality of life. And we're both focusing on that physical and psychosocial aspect of care. So you can see how palliative really grew out of hospice, because we have a lot of the same ideology. And I think for a long time before we had palliative care, nobody was really focusing on patients' illnesses and how they felt about that and how these treatments made families and the patients feel, and the psychosocial aspect of their care. you really didn't get that focus on quality of life until you moved over to hospice. And I don't think that was really fair. I think, we needed this cushion for everybody. We needed this safety net to kind of touch on all these aspects that maybe traditional care wasn't giving them. Again, palliative care is congruent with disease treatment. You can be as aggressive or not as aggressive as you want to be. Some of my patients, I treat them for symptom management, and we are expecting a full recovery. We know we're going to recover, but we're on palliative, and we are just walking through this disease process with you, treating any symptoms, anything that might arise, or just the difficulties of going through this treatment. One that I can always think of is at the Cancer Center at St. Francis. Head and neck cancer, very treatable, very difficult treatment. The whole time they have a lot of pain, a lot of side effects, and just very emotionally draining. Those patients automatically get a palliative care referral because they need someone to walk through this treatment with them. Even though we know at the end, hopefully, that outcome is going to be positive and we're going to go into remission, still need that extra level of support. Sorry. Okay. Why is palliative care important? I'm not sure where I saw this quote, but it has always resonated with me. When I was in nurse practitioner school, even when I was in nursing, we are trained to see disease. We are not trained to see suffering. When I first learned about palliative care and started studying about it more, I was like, wow, there's this whole other aspect to these patients that we're not even looking at. We're just coming in there, cardiologist, heart. Let's, your heart looks good, the treatment's working, or, for an oncologist, well, the cancer treatment's working. To what end is it working, though? How is it affecting that family? How is it affecting that patient? How does it feel to go through those treatments? The heart might look great, the cancer might be diminishing, but what is their quality of life? How does their day-to-day look? So that's really what we focus on, and I think that's so important. Just even as providers, we are constantly just looking at disease, treatment. We're not looking at suffering, and that's a big part of palliative care, is just really sitting down and talking and saying, hey, how does this make you feel? There are not a lot of programs out there that simultaneously improve quality and reduce spending. That is also something palliative care does. And it also allows the patient to be more autonomous in their care. I always tell my patients, here's what's going on, and here's your options, but there's no right or wrong answer. There's just your answer, and that's okay. And I don't have to agree with it. And even if I don't agree with it, I will support you through that, and however I can, and what that means to you. So I think that's the big thing is, what are your goals, and how can I help you achieve those goals? Normally we see a positive patient experience. As we see that positive patient experience and that quality of care, they just converge. Again, it's a great program that gives families and patients support. Okay, so the how and where of palliative care. So you can get a referral from a primary care, a specialist. Sometimes we get our referrals from hospitalized patients. It can be a self-referral. It does not have to, you do not have to get it through a doctor. You can just call us and say, hey, I would like for somebody to come out and talk to me about palliative care. So there's no gatekeeping there. Anybody can see us. When I first started, my first interaction with palliative care was in the hospital setting, so inpatient setting, having a lot of those goals of care conversations. So especially those patients in ICU when the doctors necessarily didn't feel comfortable having those hard conversations about where do we go from here. They would call us in, or when we would have a patient that was newly diagnosed with heart failure, they would automatically get a referral to palliative care, so we could do a lot of disease education, make some plans on goals of care and where this is going and what it's going to look like. And I think especially the sooner that you bring in palliative care, it makes things smoother because we're able to talk to you about your goals and set a plan. And I think, planning makes things a lot easier. Of course, things go off course, but when we have some kind of guideline to follow, that always gives people some reassurance. So again, large hospitals, small hospitals. One thing different about our program, we go into patients' homes. So that's what I do now. I do have some facilities, like nursing homes that I go into and assisted livings, but primarily I'm sitting in the patient's home. And I think that also gives a lot more insight into my patients. Some of my patients, we become best friends. I mean, there's not much more of an intimate setting than sitting in someone's home. I have patients who get up and they meet me on the couch. I have some patients, I go sit in the bed with them. They're laying there, they can't get out of bed. That is okay. I will come to you. They're in their pajamas. I'm going to sit right there and I'm going to talk to you. And it also gives you insight into what difficulties, what struggles are they facing in their home. Even little things like how are we getting in and out of the bath. And also sometimes I go and I may have one or two family members there, and sometimes I go and there's a ton of them. So I get to meet everybody. So you really get to see how your patients are living and how day-to-day life is affecting them. So I love seeing my patients in the home. I think it gives us a good insight that not a lot of practitioners get to see. So I always like this slide. And it kind of describes how palliative care works. So you as the patient or the family member, you're the bridge. And all these appointments, hospitalizations, treatments, just day-to-day things, those are the things that are kind of driving over the bridge. So it's stressing that bridge out, right? I mean, you've just got so much going on. And then palliative care is that support underneath that bridge. So we're going to come under you and we're going to kind of hold you up. We're going to be that backbone for you. So I always think that just gives a great visual of kind of what palliative care is if you're more of a visual person. And again, we can see you in any setting, hospital, in-home, nursing facilities. Another big thing is we need to know when the patient's needs exceed the PCP's capabilities. We know these, primary care providers, they're seeing a lot of patients in a short amount of time. And a lot of times what I find is it's not that they can't have some of these hard conversations or they don't want to sit down and ask you how things are affecting you emotionally or spiritually, but they're just confined to that time. The hospital system, they're making sure that they're turning, you've got to see this many patients in this amount of time, and they just don't have the bandwidth for it. So that's kind of where we come in. Normally, my new patient appointments take about 2 hours or more. My just patients that I've seen before that I'm checking in on, they can take anywhere from an hour to an hour and a half to 2 hours. So I have the flexibility to spend that time with y'all. You're not going to feel rushed. We can just get in there, get to the nitty-gritty about how things are going. Sometimes I go see my patients, and they're like, you know what, I'm doing great. Hey, bye, and that's it. But I like having that flexibility of being able to really sit down and take that time with them. And I feel like in this world today where everything is so fast and just, we're constantly on a timer, that with this program, we don't have to worry about that. Okay, so process of care. When I go in, I'm hopefully going to know a lot about you already. I'm going to know, what I'm going in there for, what our disease process is. And then we're going to sit down and we're going to get into the nitty-gritty details. And I always tell people it is a very, just laid-back conversation. It is an open conversation. So I want not only the patient telling me what's going on, but the family members, because sometimes what the patient thinks is happening, oh, well, I shower by myself, or, I make my own meals, and then the family member's like, we're helping a little bit more than that. So what I start with is I go through activities of daily living. So ambulation, showering, toileting, dressing, sleeping. I want to know how that looks. If you have somebody helping you, how much help? Are they, putting one arm in a sleeve? Are we getting one leg in the pants? And do those activities make you tired? Are we losing weight? And then we talk about baseline for as I see you, to go back and say, well, here's what we were doing 2 months ago, 3 months ago, and here's where we're at now. So it's, because when we're in the midst of it, sometimes it's just hard to see the forest for the trees, especially for those family members that are in it day in and day out. And again, that relationship, because we're seeing you and we're spending so much time with you and we're seeing you in the home, we really cultivate a very special relationship with our patients. We also help with finding resources in your community, things that can help you depending on what your needs are, providing materials, and then, also just realizing that those PCPs, sometimes they just don't have the time or the resources, and kind of filling in those gaps is basically what we do. Again, let me go back, actually. So another thing that we want to do after we do those assessments is I like to ask patients and families, what has the doctor told you about your disease? Because that lets me know how much you know. There are some patients that I go into and they don't know a whole lot about their disease or their disease trajectory, how this disease is going to look, 5, 10, 15 years down the road. There are other patients that are very well informed. They have all the resources and they just need that. They just want extra resources. They want me there to be an extra layer of support. There are other patients that have a lot more needs. And that's okay. And I just like to know what your baseline knowledge is on that disease, and then that lets me know how much teaching I need to do. And then I like to talk about, what are your hopes? What are you hoping is going to happen with your disease? What are your fears? And I also like to know, what are things you enjoy doing? What do you consider quality of life? What do you consider, if you weren't able to do X, Y, and Z, do you feel that would mean that you don't have any quality of life? And I know some of these conversations are difficult to have, but they're so important to have. And we don't have to have them every time, but it is important. And the more that we have these conversations and the more that I know about your goals, and your hopes, the more that I can support you and help you meet those goals, and the more autonomy that it gives you as a patient. Advanced care planning, that's always a conversation nobody really likes to have. It is difficult. It's things we don't want to think about, but it is good to have those conversations because it allows you to tell families, if this happened, this is what I would want. Not only does it allow you to be in the driver's seat and make decisions for yourself, but then in the instance, the horrible instance, where you aren't able to speak for yourself, it gives your family peace of mind knowing this is what they want, so I can do this. It doesn't leave them guessing on, what should we do, which causes a lot of turmoil between families. So it's so much easier when we already have these things planned out, and it just gives us a roadmap of what to do. And again, I don't think anybody would, want to have something done to them that they don't, they didn't want to begin with. So that's why it's so important to have those conversations. And we're able to walk you through it. We can do, some family members, they just want to do it alone. Patients want to have it alone with the nurse practitioner. Others want to have a family meeting, and we're there to kind of cushion it all and just walk through it. And then, it also goes back to, getting that financial help, making sure everything's laid out so it's one less thing you have to worry about. Physical aspects of care, the assessment should focus on relieving symptoms, improving and maintaining quality of life and functional status. I think we touched on it earlier. Your symptoms can include pain, shortness of breath, fatigue, nausea. There's no symptom that we don't treat. our care is always going to be delivered in a patient-centered care plan. With what it's got to be congruent with what the patients and the family members want. You know, we sometimes sit down and we will go through options. So if we take this medication or we plan for this treatment, what is that going to look like? So one of my big things when I'm trying to help patients make decisions is I want to educate them on, if we take path A and you decide to go, let's say this patient is going to go on chemo, okay? That's what this is going to look like. Or yesterday, I had a patient, he's 65, he's diagnosed with multiple myeloma. He is severely debilitated, struggling with walking, pain. Oncology set him up with a treatment plan. However, he said, if we go forward with this treatment plan, you're not going to physically get any better. You may not get worse. That's the hope, right? That we don't get worse, but you're not going to get any better. This guy, he had a very active lifestyle before all of this, was very career-driven, and he was just very honest with me, and he said, this is not a quality of life for me. And I said, okay. And I said, so if we're thinking about not treating this disease, here's what this is going to look like in the future. And I think that's the most important thing when we're making those big decisions. I just want to make sure that you know what each path is going to look like. And as long as you know what each path is going to look like and you're okay with that, then that decision obviously is ultimately up to you. I just want to make sure that you're educated when you make that decision. So he ultimately, that was not quality of life, what he is living. So he opted to not pursue treatment. And again, there's no right or wrong answer. That might not have been what I would have chosen for myself or that any of you would choose, but that's his decision at the end of the day. And that's what he's comfortable with. And that is what I'm there to do, is to support that decision. Psychological and psychiatric aspects of care, I feel like that is something we do a lot of. Some treatments, just the back and forth to the doctors, just everyday life with these disease processes can be hard. And it's not only hard on the patient, it's hard on the family too. So I always make a point when I'm in these appointments, I look at the family members, I'm like, are you okay? How are you doing? Because we've got to look at the whole picture. We've got to look at the family, everything that goes into this patient and who's providing care for them, and how that ripples out around them. And again, I'm constantly watching for signs of family members struggling with psychological issues and trying to find resources for them too, because you cannot take care of someone if your cup is half full. Okay, you've got to take care of yourself. That is one of the biggest things. I remember that's one of the first things I learned in nursing school. They said, when you're going to go do these 3-hour shifts, and you're going to just, be turning your cup over, right? You're just going to be taking all of you and pouring it into these patients. On your days off, that's what they told me. They said, you have to find how to fill your cup back up. You've got to take care of yourself in order to take care of someone else. So finding those resources that provide y'all with, whether it's respite care or just some time where you can go breathe and take a moment and refill your cup. I think that's huge. So it's not just the patient we're seeing, it's the entire family, it's the caretakers. So I think that's kind of what sets us apart from a lot of other specialties. And then just, sending out those appropriate referrals, doing what we can. We do have a social worker. She is, I think, one of 2 palliative care certified social workers in South Carolina. She is a wealth of knowledge. I love her. Patients love her. So it's really great to have added her to our team, because we can give these patients, all the resources in the world. We're covering all the bases. Okay, so social aspects of care. again, I'm coming into your home, so it's really easy for me. A lot of patients will have me walk around their home. Look at my bathroom. What do you think about this? How do you think about this? How can we do this better? For some of my older patients, I'm going in there and saying, okay, we might need to get rid of this rug. Fall risk. I'm constantly looking at what is going to cause an injury in the home, or how can we just make things run a little bit smoother. We're also, trying to help with financial barriers. That goes back to our social worker with any resources that might be available. A lot of times my patients struggle with access to care, transportation. I did not realize until I started home care services how many patients there are, just let's say in Greenville County, that are homebound, cannot get out of their home unless EMS were to come and put them on a stretcher. So, helping with just access to care, and, that was huge to have providers come into the home, especially when you can't get out. All they're doing is telehealth visits. So, I think for them, having somebody come in and sit down face-to-face is very refreshing for them. Another part is spirituality. That's always a huge part, and I feel like, as a provider, and we're dealing with so many different cultures and ethnicities, we've got to be up to date on the different ins and outs. I don't have to be an expert on every religion or anything like that, but I want to know about them, and I want to know, what kind of a spiritual relationship you have, so that I can be a part of that and help you with that and bring that into your care. So I really like to stay kind of up to date on that. And then cultural aspects of care. What are important to you? End of life care is so different for different cultures, and I want to make sure we honor that we don't do anything that would upset you. So kind of knowing what your values and belief systems and traditions are, I want to incorporate that into your care. I think that's very important. Okay, so back to kind of that advanced care planning, it really allows patients to express their goals, their values. They're not only, telling us about it, but their families, letting us know their wishes so that we can follow those, right? Different medical orders could be like a DNR, comfort care, a PULSed form. And again, we can help walk you through those. And I know those are very difficult conversations, but we're trained to walk through those and help y'all with some of those decisions. One thing we are seeing is, some of the top organizations, that have been on the honor roll for patient care, they all have palliative programs now. So there's a common denominator in all of these award-winning best hospital things is that they all have a palliative care program. So that's kind of telling us something, right? That palliative care, there's a need there. That's what we need. So I just think that's huge. You can really see this program growing. I think when we first started out, we were maybe one of two in the area that offered palliative care, and now you're starting to just see palliative care boom. I think when I was in the hospital, not a lot of people outside of the hospital, unless they had encountered palliative care, knew about it. And I still get that question, well, what is it? And again, like I said, it's such a loaded question, because it's like, well, what are your needs? Because we wear so many different hats. So who can benefit? Obviously, your high-risk patients, socially vulnerable, exhausted family caregivers, patients with cognitive impairment or multiple comorbidities, dependency, functional dependency. Really, I always, just as a broad statement, say anyone that has a chronic or life-limiting illness can benefit from palliative. Now, whether that be a one-time visit where we come in and we discuss goals of care, which I've done, and that's all they wanted, and we accomplish that, or whether I stay on with you through your disease process. So really anyone could benefit, because even if you do not have a serious illness, it's still important at some point to have those conversations about what are my goals for my future, for my health. So I think those conversations should be had for anyone, really. Palliative care, we also see, I think with a lot of palliative care, people automatically think patients with cancer. I see patients with heart disease, liver disease, advanced lung disease, HIV, AIDS, Alzheimer's, dementia, disabling strokes, neurological diseases. So there's not really any disease that we discriminate against by any means. We can see anyone. So key takeaways, big thing, quality of life. That is my hope for everyone in this room, is that you have more good days than bad days. And that if you take anything away from this, it is that palliative care, we are going to focus on your quality of life and figuring out where are there some gaps, how can we fill in those gaps, how can we make you more comfortable, how can we make every day better. Comprehensive care. So you're going to get the social worker, and a lot of times what I'm doing is I'm on the phone with the oncologist or your cardiologist or your pulmonologist. So instead of you being on the phone trying to fill in all these gaps, I'm bringing this full circle for your care. So I'm making all the calls, doing all the things to try to bring your goals full circle. Palliative care is most effective when started early in the disease process. Again, it can be alongside curative care. At the end of the day, it relieves suffering, whether it's physical symptoms, emotional stress, or psychosocial issues. It's always going to be individualized care. That's why I sit down and go through all of those aspects of care with you, so that I can tailor a care plan based on you and your family. Again, we provide family support. So I don't know that I've ever been to a doctor's appointment where I may have had like a loved one with me and the doctor says, well, how are you? Asking my family. So I think that's a big part of too, is that we're providing that family care and support. Another thing is we provide a holistic approach. So we can do all the Western medicine things, but then I'm also okay with doing the holistic things too. So it's whatever brings you comfort and peace of mind. Crisis prevention, that goes back to making those plans about if this happens, this is what I want to do. If this happens, and again, plans can always go off course, right? But it does help when we do have some kind of plan laid out, and it allows us to not go into that crisis mode. And then I'm constantly reevaluating. Every time I go in, that goes back to that assessment that I do day one. How are we changing? Are we improving? Are we declining? And just reassessment. And as things change, we're going to sit down and maybe we need to reassess those goals. We need to go back over them because since things are changing, our goals might be a little different. But again, biggest thing I think is with palliative, you can be seeking aggressive treatment, and the biggest thing is we're going to help you focus on quality of life. All right, and that's it. Questions? Yeah. Yeah, so, trying to find, different ways to communicate. I've gotten really creative in the past, and maybe sometimes even bringing in like speech therapy to assist with that. But then, there are times, let's say with my patients, they're maybe further along with dementia, and we're just, even if we could we're not going to really get a clear response out of kind of their goals of care. And a lot of times we do just have to rely on their family members and who knows them the most, because a lot of you, you're in there day in and day out, and y'all notice those little cues, right, from your family members that, well, this makes them hurt, or they're unhappy, or, and that's when I really rely on y'all for that, because y'all know all the little subtle cues. You know them probably better than y'all know yourselves sometimes. Yes. Yeah, so, and we actually do a lot of that. We do a lot of family meetings where we sit down with everybody. And one of the biggest things I like to start with is asking everyone, especially if we're talking about moving from palliative to hospice, I like to gather what are their fears about hospice. And that's the root of it. Figuring out what that fear is, because that's what that hesitancy is coming from, is from a fear. And a lot of times, their understanding of hospice. I think one of my biggest things with a lot of patients is they're like, well, I have to go off all my medications. No, you don't. They think that you can't go. I had one patient that thought, if I go on hospice, I can't leave the home. Oh, absolutely. If you feel like getting out of the house and you want to go get an ice cream, or you want to do it. Do it. We want you to have more good days than bad days. But I think the biggest thing, and a lot of people like to have that third party there, so like a palliative provider to kind of guide that conversation, right? Because sometimes, especially with family emotions, it can get a little muddled. So we can kind of bring everybody back on track. But at the end of the day, I think, if you were just going to have a conversation with family, I think it is gathering what those fears are about that transition. And then from there, we can figure out, are those legitimate fears? And if they are legitimate fears, a lot of times what I have to tell families is, we're on this path, and this is the path that God has set us on. We can't get off of it, but what we can change is how this looks for us. So we're still on the same trajectory, but it just may look a little different with how much care we receive and things like that. Yeah. Yes. Yes. No, most insurances, Amy, do you? Mm-hmm. Yes. Yeah. And that's what, when you think about palliative care, just think about like going to a specialist. So you can have palliative with all the other things. So it doesn't preclude you from any other service by any means. It is just like going and seeing a cardiologist, a pulmonologist. So, yeah. But with palliative care, as I will say that obviously the difference with respite is where somebody would come in and provide you with some relief. With palliative, it's more of me, the practitioner, coming in, doing, more like a doctor's visit, but obviously more focused on the patient as a whole. But, unfortunately, we don't personally provide that respite care. Yeah. Yes. So really anybody can provide palliative care. I don't have, like, our service doesn't have a lot of RNs that but really, when you look at palliative care as a whole, other than, providing medications for symptom management and things like that, really anybody can provide palliative care to a certain point. And, with our hospice program and our nurses, if you think about it, what they are providing is palliative care encompassed in hospice. Yeah, that was a good question. Yes. I will say, I mean, I can't speak for every program. Ours does. A lot of providers like palliative care because we might have a little more flexibility in prescribing some of those bigger drugs, like pain medications, that maybe some of the hospital system doctors are getting their hand slapped a little bit for it. So we have a little more freedom and wiggle room in that. So I know our program does, and I would like to think that all palliative programs can do that, considering, you know, that's kind of what it's about. Mm-hmm. Yeah, so you're talking about like within like outside physicians? Oh, yeah. So once a week at least, we are sitting down in a meeting, and my Dr. Tiffany Richter and Dr. Carrie Bradford, we sit down and we individually go through our high-risk patients. Or if there is a patient that may not be necessarily high risk, but I'm like, you know, we're working on this pain medication, this pain management, and we're just not getting there, we'll sit down and figure it out. And there has never been a time when I've been out in the field that I haven't been able to just pick up the phone and call them and say, here's what I've got going on. This is over my head. What do you think? So we're constantly involved. They know almost every single one of my patients by name. We keep a spreadsheet, and we go through and do all the checks. So we're constantly doing a interdisciplinary approach. Yeah, so, well, and I think that goes just beyond pediatric cases as well. I have patients whose symptoms really wax and wane, or they may go through remission stages. And I do have patients where, we kind of get to the point where they're doing so well, and I'm coming in and they're like, what are you doing here? We don't need you. So yeah, we can, pause care, come back to it when we need to. So yeah, absolutely. Absolutely. Our care can be as fluid as we need it to be. So unfortunately, the sicker you are, I'm going to be coming weekly or every 2 weeks. If you start doing a lot better, then maybe that looks like every 4, every 6 weeks, every 3 months. And then if it changes again, then we'll crank those visits up. So it's very fluid. So there's no one set. Everybody care is very individualized based on needs. And can I? She had her hand up too. Can I answer hers? Sorry. Mhm. Yes. So I actually will give them calls. Huh? Oh, she was asking about patients, other doctors, like outside of our program, and how I communicate with them. So a lot of times I'm calling them and letting them know, here is, what's going on with our patient. Here's how their symptoms are doing. I can be as involved or as little involved with that aspect of care as the family wants me to be. But a lot of times they need my glimpse into the patient's world. All right, thank y'all so much.
All right, thank you, Ashton. And I know that they'll be here for a little bit. I know we've got a break for about the next 10 minutes here. I think you have some cards, and you're willing to be kind of to help with any communication or connection if you want to talk a little bit afterwards or beyond today. So I know we're going to break now. For those who are staying for the dystonia management, will be in here, and the next breakout, financial planning, is next door in Homestead. So we'll see y'all in 10 minutes. Thank you.